Mr. Sami, thank you for coming today to the clinic. How are things with you today?
Thanks, doctor. I'm okay. In fact, if it wasn't for the rising PSA, I wouldn't have thought that I have prostate cancer.
Well, correct. Actually, your PSA is rising, but when we did for you the CT staging, we found only slight progression in the bony metastasis, but there was no metastasis elsewhere.
This is encouraging, and as we discussed last time, I'm interested in treatments. I think the last time you mentioned something about a T therapy. Did you call it Sipuleucel-T cell therapy?
Yes, correct.
I just wonder if you could tell me more about this treatment, doctor, and particularly if you could tell me more about the life extension results with this treatment. Sipuleucel-T is an active cellular immunotherapy, a type of therapeutic cancer vaccine consisting of autologous peripheral-blood mononuclear cells that have been activated ex vivo with a recombinant fusion protein consists of a prostate antigen that is fused to a GCSF. Sipuleucel-T has shown an overall survival benefit compared to placebo in patients with metastatic prostate cancer. Patients on the Sipuleucel-T group had a 3-year survival rate of 34%, a median increase to survival of 4.5 months, and a median survival of 25.9 months. In contrast to overall survival, the time to objective disease progression did not differ significantly between the study groups. This treatment is indicated for patients with asymptomatic or minimally symptomatic disease, no liver or visceral metastases, life expectancy more than 6 months, and ECOG performance status of 0 to 1.
So our next patient is Mr. Hassan, who is a 60-year-old gentleman who had a radical prostatectomy last week, and we are reviewing today his post-op histology. Of note, his PSA post-surgery is less than 0.1.
Right, so the surgical specimen showed Gleason score 3 plus 4, 7, prostate adenocarcinoma. The surgical margins were negative and no extraprostatic extension. However, there is an evidence of seminal vesicle invasion, no lymph node involvement.
Okay, well, he is fit and well post-surgery, and he is keen to explore treatment options adjuvantly. I don't know what is our input from our oncology colleagues.
Patients with adverse pathologic findings, including seminal vessel invasion, positive surgical margins, and extraprostatic extension, may benefit from adjuvant radiotherapy compared with radical prostatectomy alone. This treatment is associated with a reduction of the PSA recurrence, local recurrence, and clinical progression of cancer. However, the impact of adjuvant radiotherapy on the systemic recurrence and overall survival is not as clear. Biochemical recurrence is defined as undetectable PSA that becomes detectable after surgery and increases on 2 successive measurements, and those patients should be considered for salvage radiotherapy. Abiraterone plus EDT should be considered in patients with N1 who are treated with radiotherapy to prostate and pelvis. Dr. Muhammad, can I ask a question, please, about a patient?
Oh, yes, sure.
So it is about Mr. Ali, who is the gentleman with known prostate cancer with bone metastases. He was admitted yesterday with a tonic-clonic seizure. We did an MRI scan of his brain, but didn't show any space-occupying lesion. I'm not sure what's going on here.
That's weird. So the MRI was normal?
Yes, indeed. His MRI scan did not show any suspicious lesions. His blood results are all within normal range. His observations are within normal range as well. So there's nothing to explain why is he having the seizure.
Does he have any risk factor for seizure?
No risk factors whatsoever. The only thing of note, he was started a couple of weeks ago on a new treatment for his prostate cancer. Enzalutamide is a relatively new targeted therapy that targets the androgen receptor signaling pathway. A phase 3 randomized trial of enzalutamide versus placebo in the second-line setting in more than 1,200 castration-resistant prostate cancer patients reported an overall survival of 18.4 months versus 13.6 months favoring enzalutamide. The enzalutamide was superior in all secondary endpoints, such as the proportion of patients with a reduction in the PSA level, the soft tissue response rate, the quality of life response rate, the time to PSA progression, radiological progression-free survival, and the time to the first skeletal related event. Rates of fatigue, diarrhea, hot flushes were higher in the enzalutamide group. Interestingly, enzalutamide has been reported to cause seizures in less than 1% of the patients.
Good morning, Dr. Ahmed. Can I have a minute of your precious time?
Yeah, sure. Have a seat, please.
Thank you. I have here Mr. Henry, who is a complicated case, and I need your advice on his case.
Yes, go ahead.
Do you mind reading from my endorsement?
Yes, of course, by any means.
Thank you. Mr. Henry was initially diagnosed 2.5 years ago with a metastatic prostate cancer to the bone, lymph node, and liver as well. He was treated with anti-androgen blockade, and about a year ago he was admitted with visceral crisis due to disease progression, and was found to be a castrate resistant, so docetaxel was commenced.
Good.
He have indeed a clinical, radiological, and biochemical response, but the chemotherapy had to be stopped due to a neuropathy after a 10 cycle of docetaxel, and he was observed very carefully. His PSA started to rise with a recent reading of 25, and the bone scan showed at least 3 new bony mets, but no other systemic progression on the CT.
Okay, so how is he clinically now?
He is indeed symptomatic from the new bony mets and with pain, but otherwise he is well.
Have we done an NGS on him?
Yes, indeed, we did. The patient tumor is microsatellite stable, and the BRCA1 and 2 are wild type.
Sipuleucel-T is an autologous active cellular immunotherapy that received FDA approval based on the IMPACT study. However, Sipuleucel-T has not been studied in patients with visceral metastases, and as this patient is known to have visceral disease, Sipuleucel therapy should not be offered in his case. Radium-223 would have been an option for a patient with symptomatic bony metastases. However, this patient has disease outside of the bone, in the liver and lymph node, so this would not be an option to offer as well. If the patient has had macrophage instability high, then immunotherapy such as pembrolizumab could have been an option. Similarly, patients with BRCA1 or 2 mutation could benefit from a PARP inhibitor such as olaparib. Palliative radiotherapy to the painful bony metastases would also have been a reasonable recommendation.
We hope you liked our video. This is acting for clinical education.
And don't forget to check the reference down below.
Please like, share, and subscribe. And don't forget to join us every Thursday, 5 p.m. Greenwich time.